basically the definitions. Sickle cell disease is different from sickle cell anemia. We all know that, so I'm making some assumptions here. It's an inherited disorder of hemoglobin where individuals inherit two abnormal hemoglobin. If you see the definitions, they're almost the same thing. But I'm highlighting the difference. Two abnormal hemoglobin genes, one of which must be S. Okay? In this case, both of them are abnormal, but one must be S. Now, anemia, you have two abnormal hemoglobin genes, both of which must be S. Then we talk about trait. You have a combination of one abnormal hemoglobin, which is the S, and then a normal hemoglobin. Okay? The pattern of inheritance is autosomal recessive. Okay, so for it to manifest, it must be full dose. Okay? Then we have different types of sickle cell disease. Most times we refer to sickle cell disease here as SS, the SS type, okay? But that's actually sickle cell anemia. But technically that also falls in the definition of disease because the two of them are abnormal. Now, we have SC, we have SD, we have S beta tau, and then we have SE. There are more of this. Okay, the common thing among them is the S. Okay, and each of these have different manifestation, different management. That's why there's not one single protocol for managing all of them. Now, sickle cell patients. Okay, now we're using sickle cell disease. Sickle cell disease patients, they present in two states. They only present in two states. In steady state, that's where they walk about apparently healthy or when they're in crisis. Okay? So when they're in crisis is one of the four. There used to be five, but now we talk about four crises. Vaso-occlusive, which is what we'll be talking about today, and then we'll have the hemolytic crisis, aplastic crisis, and sequestration crisis. I assume we know what these are and go straight to the one we're talking about, vaso-occlusive crisis. Okay, so it's also called acute pain crisis. Okay, from VOC or acute pain crisis, we all know that this has to do with occlusion of the vessel and pain. Okay? So it's the most common crisis encountered in sickle cell disease patients. It's worthy of note that in crisis, it mustn't be one. They can present with a combination of two or even three at the same time. Someone can be in vaso-occlusive crisis and hemolytic crisis at the same time. In fact, that's a very common presentation. You see them in VOC and also deeply jaundiced. So that's a combination of vaso-occlusive and then hemolytic crisis. They can present in vaso-occlusive crisis and sequestration crisis. Okay? Now, the aplastic crisis is usually the boss. It comes alone. Because in that there's a cut in production of red blood cell. It's temporary though, but it can be fatal. Okay? So it comes alone most times. Now, back to VOC. VOC results from occlusion, like the name says. By our physiology, when you occlude a blood vessel, the distant tissue suffers. And what happens? They're deprived of oxygen, they're deprived of a nutrient, and what ensues is an ischemia. And ischemia leads to inflammation. Inflammation leads to production of inflammatory cytokines that elicit pains. Okay, so the hallmark of this condition is severe bone pain and then features of ischemia. Okay, depending on the organ affected or the part of the body affected, presentation might vary. So, part of physiology, like we stated, the original defect is the inheritance of the abnormal gene that leads to the production of abnormal hemoglobin. The abnormal hemoglobin has a particular property, okay, that makes it different from the normal hemoglobin. When subjected to stressful conditions, which include deoxygenation, stress from other pathogens, they polymerize and then deform the red cell. Okay, when this occurs, it's reversible till there's severe membrane damage that is irreversible. And once that occurs, the flexibility of a red cell, the red cell passes through vessels that are like 4 times smaller than it because it can deform to pass through any blood vessel. But once they become rigid, they can't flow through those vessels. And then, since they can't flow, they block it. And once they block it, all the ones coming behind, even if they are flexible, can't pass. Okay, so there's like a hold up, and in that hold up, there's no fresh air. So more red cells will sickle there. So until you do something, it's a vicious circle. It will just continue to progress and get worse. Okay, and we already talked about inflammation that ensues, ischemia. Now, why I say this is complex is there is vasoconstriction. When we're in med school, all we know about sickle cell was that there's sickling, the sickling blocks the vessels, and then it causes occlusion and crisis. We know better now, okay? There are sickle cell patients that you don't even find one sickle cell in their blood. Okay, so the pathology goes beyond just the sickling. Okay, there are molecular mechanisms that worsen that. I'm talking about this because of the vasoconstriction. Okay, sickle cell anemia, or the inheritance of the gene, affects hemoglobin. It affects membrane rheology. It also affects membrane presentation. Okay, they express adhesion molecules that makes them sticky. Okay, one of the new drug that was released for sickle cell, what it does is target P-selectin, okay, to block P-selectin, and that works very well for sickle cell. So it goes to tell you how this adhesion molecules play a great role, okay? And one of the reasons why we also do a lot of transfusion is because newer red cells seem to have those P-selectin more than the old ones. So you try to transfuse these patients to prevent them from making their own red cells. Okay? So would talk about the vasoconstriction here. It's as a result of hemolysis. Once these red cells get sickled, they can be broken down and they release free hemoglobin. The surgeons know that that's not a very good thing to happen because of the effects on the kidney. But also, it affects the arginine pathway that leads to mopping up of nitric oxide. And nitric oxide causes vascular tone. It balances vascular tone. So once that is absent, you have vasoconstriction, and that worsens the occlusion you get in sickle cell. Okay? There's endothelial dysfunction. The ischemia at the point of occlusion also affect endothelial cells. Endothelial cells get damaged and they are slaughtered. The subendothelial surface is exposed. You are exposed to thrombosis, okay, because of adhesion of platelets to the endothelial surface. Then there's also hemostatic activation and prothrombotic state, and that's what we just talked. And then we talk about oxidative stress and free radicals. Okay, so from this alone, you see the pathology of sickle cell is multi-pronged, and thinking there will be ABC protocol to handle this, it's going to be a futile effort. Now, we all know that ischemia is a very bad thing. Most of the organs we're talking about, if they are dead, most of them, if they heal, they'll heal with scar or not heal at all. Okay, the orthopedic surgeons know we are their best friends. AVN and all are from vaso-occlusive crisis. Repeated vaso-occlusion to the head of femur and all leads to the death of the head of femur, which will need a very expensive surgery. So, understanding the mechanism of vaso-occlusion is key in the management, which is what the topic for today is. And any delay, just like my colleague said earlier about management of head injury, time is of the essence here. Okay? All right. Now, management of vaso-occlusion, that's the topic for today. We're going to be discussing the principle. You use your judgment as a physician to know when and when not to act. So the principle is simple. You eliminate the trigger and then you support the patient back to health. It's that simple. Okay? So let's say a patient had an acute malaria and that was the trigger. First things, you resuscitate this patient as per emergency. You treat malaria, malaria is gone, then you resuscitate this patient. The patient should be back and healthy in the shortest possible time. And usually, the trigger might not be one. So, your history, clinical examinations might point to the actual trigger. Like one of the most difficult ones for us is UTIs. UTIs might go silent. The patient himself might not be aware he had UTI. Okay, until you do your analysis, and also you must have high index of suspicion. We talk most of the common things, even though malaria in this part of the world is overtreated, overdiagnosed and overtreated. Okay, yeah. But you can't be too, you can't do too much in treating malaria and sickle cell. Okay, so when we talk about supportive care for sickle cell patients, we talk of pain management, we talk of rehydration, physical therapy, and correction of anemia where necessary. Okay, so I made a list of some of the triggers. The list goes beyond this. So one of the first ones that people ignore, and one of the biggest fights we have with these clients, dehydration. For some strange reason, most sickle cell anemia patients don't like drinking water. So I feel that's like you're rushing to hug your enemy. Okay? That's one of the main triggers of VOC in them, but they don't like to drink water. Okay? So we should be able to assess dehydration in them when we see them and think of how to correct dehydration. Infections, parasites, bacteria, fungal, all three can trigger a crisis in them. Extreme weather just is very cold. Okay, so the December, we call December, January our sickle cell period. That's when we have the whole world is full of sickle cell patients, because that's when the weather in just is at its best. Okay, we have stress. And when we say stress, like if Dr. Alfin was a sickle cell anemia patient, we'll be wheeling him out from here. He was in the theater yesterday and he wants to go back today. We'll be wheeling him out of the theater if he were carrying the S genes. Okay? Then emotional. Okay? Guys, you got heartbreak. It can trigger crisis. Your account balance is getting progressively low, can trigger a crisis. High altitude, okay? Plateau state is one of such area. High altitudes have low oxygen tensions, but it's not that common here, thankfully, and most people here have adapted to it. Smoking, okay? Smoking, we know the issues with smoking. In sickle cell, it's even more, okay? You have anemia already, you have pathology in the lungs because of pulmonary hypertension in them, and now you're adding cigarettes to it to reduce the exchange surface. That's going to worsen it definitely. Alcohol for them, okay, acts like a diuretic. For everybody, acts like a diuretic. Our first point was dehydration. You don't want to do that. Then you talk of medications, beta blocker, you also know what that does to vascular tone. All right. Hormonal changes. Okay, this is more important in ladies. Okay, for some strange reasons, you might just have hormonal changes. that would alter blood viscosity and then trigger crisis. There are critical load for hemoglobin S that you need to have crisis. Okay, that might just be in the balance when these hormonal changes occur and it will tip you there. You as a physician might just be there clacking and looking for the history, but that might just be your trigger. Okay. Then nutritional deficiencies. We always spend hours counseling sickle cell patients on supplementation and nutrition. Okay, for an individual, your body has a capacity to double production of blood about 12 times. Okay, what it means is if a parasite gets in your body and consumes all your blood, you will need about 12 of those parasites before you can come down with anemia. Parasite being an example. Okay, it means your body can increase its production 12-fold. So once you have a patient with anemia, and that's one of the points I want to stress here, as doctors, we make that mistake. You see a patient in your clinic or at your post, you see a patient presenting with PCV of 29, you say, this person has mild anemia, let's give him Atenix. Not a wise move. Most patients would present with anemia by the time they've exhausted that 12-fold capacity. So if they're presenting to you with anemia, it means it's already serious. So giving hematinics is just making the hematologist's job harder, because that might mask what the original problem is. Okay? So the last one, sleep apnea. Most people don't even know they have it. Okay? You might go to bed in the night, everything is okay for you, you just close your eye and you think you've gone. But some people accuse spirits, but it's not. It's an ailment that most people go about. Most times now there's an app for you to record your sleep. If you use that app, then you know you really have a sleep defect. Okay? Some people hyperventilate in the night, some people the respiration drops, some people can get up from their bed, do things and wonder who did it in the night and all that. That might affect your oxygen saturation and then trigger crisis in them. Okay? So now, management proper. We have the acute and the chronic management. Now, to put it simply, we'll talk about pain relief with analgesic. That's the first thing, because most sickle cell patients will present to you because of the pain. Okay, like I usually joke with them in the clinic. I say this like the S in the condition is for stubbornness. They are actually very stubborn. If they present, it means they can't do anything anymore. Okay, so by the time they're presenting, you have to deal with pain. Okay, and you hold nothing back. You hold nothing back. What means you throw all the painkillers at them. So we'll talk about the pain. Antibiotics or antimicrobial is a better term, because you might be dealing with bacterial infections, parasites like malaria or worms, and then fungal infections too. Then fluid replacement, I'll come to those. Oxygen therapy and rest. Now pain. It's a hallmark of VOC. Okay? And you have to promptly and adequately deal with pain. This is a very difficult task. Most sickle cell anemia patients deal with addiction. So I have clients that present to the clinic or fake crisis to come on admission because they need opioids, because they're addicted, and they are very good actors. So you have to, the difficult part as a doctor is this drama or is the real deal? If it's the real deal and you think it's drama, you're punishing the patient. If it's drama and you think it's the real deal, you are feeding the addiction. So you have to stand in the middle and make prompt decision. We sometimes use placebo, but I also discover the They are very intelligent. Okay, you give water for injection, they tell you, no, this is not penta. Okay, some of them can differentiate penta, they can differentiate PCM, they can tell you all the IM injections. You give them diclofenac, they know. Give them water, they know. You give them penta, they know. Okay, so you have to be faster and smarter. Okay, now pain in sickle cell can be classified into acute, chronic pain, and neuropathic pain. Okay, acute is what you deal with. Okay, can extend even to a month. It's as a result of the ischemia and tissue damage. Okay, chronic pain basically is from the complications of what you failed to do in the acute stage. Okay, those organ damages might lead to more permanent pain, which we describe as chronic pain, and then the neuropathic pain is from nerve injury. So there's actually no tissue damage happening, but the nerve is sending wrong signals. Okay, so for that the management is different. The approach depends on the type of pain you're dealing with. Okay, now the principle management of pain in them is simple. You assess the pain. Okay, there's a pain ladder. You try to determine how much of pain they're going through, and then how much that is impacting on their daily life. And then based on that assessment, you adjust your medication accordingly. Now the mistakes we make is trying to wait to secure a line while the patient is screaming their heads out. Okay, we can't access your line, we're waiting for the surgeon to come and do a cut down. That's wrong. We need to do everything we can, like use subcute medications or oral. Okay, morphine preparation is available now to us. Okay, so that is the preferred analgesic for sickle cell patients. Okay, then you also talk of diclofenac, or the non-steroidal anti-inflammatory drug. It's the most effective but not the preferred. It takes more care of skeletal pain than the opioids. But what we don't want is the effect of NSAID. Sickle cell disease in itself is pointing a double barrel at the kidney. So if you throw NSAIDs in, you're adding a machine gun to them, pointing at the kidney. Okay, so when we fall to NSAIDs, we combine it with other medications, and then you take it out at most 3 days. Okay, well then again, the patients know NSAIDs works for them more. So they buy it, and here you can buy anything. You walk into the pharmacy, you have your money, you get anything. Okay, so we adjust medications as needed, and then we use adjuvant. We talk about neuropathic pain, right? Neuropathic pain will not respond to NSAIDs and all that, so we use other medications, gabapentin, tricyclic antidepressants, neurovites, and all that. Those improve nerve health and then improve symptoms of the neuropathic pain. Now, the classes of analgesic commonly used is opiates, NSAIDs, and centrally acting agents where available. We also use PCM and some combinations. Okay, there are combinations of some of these drugs accessible to us. Sometimes, if sickle cell disease patient might be on 3 different classes of analgesics. Okay, because if it doesn't work and you reassess your pain, you have to add. There's nothing like I'm being too generous. Once there's pain, you have to add medications to it. Okay. Now, so the other acute management, we talk about infections, use antimicrobial. You can vaccinate the patient in case against some of the common infections in them. Personal hygiene is key in preventing infections in sickle cell patients. Now, we go to transfusion. There are different types of transfusions for us. Transfusion in sickle cell is not as simple as we're upping the PCB. Okay, we usually have this running battle with ONG for our sickle cell patients that are also in ONG. Okay, we've kind of strike a balance. We stay on 30, and that's just to make our colleagues happy and stay on a safe zone. Each sickle cell anemia patient has a steady state. If your steady state is 17, if you raise the PCV to 100, you're wasting that blood. The patient will break it down to 17 and stay there. That's why it's called the steady state. That's where they prefer. But the pregnant ones, or they're going in for a surgical procedure, would like to raise it to 30. And for patients you don't know their PCVs, raise it to 30 and let them break it down to where it's comfortable for them. Okay, but blood is a scarce resource, so we don't like to waste it. Okay, now the sickle cell anemia patients are more resilient than me and you. They can walk into the clinic with PCV of 9 and they are gisting with you. Okay, they've been there, they are comfortable there. Okay, if they are not showing any sign of decompensation, leave them there. Okay, the downside of it is they progress to that low point at the expense of their heart. Once your PCV is getting too low, your heart has to work extra to get the blood around, and you know what that does. Cardiomyopathy you have hypertrophic cardiomyopathy, and that even worsens cardiac output. Okay, so one of the first things we do when we see a new sickle cell patient is establish where the steady state is and try to keep the patient there. Okay, we do urinalysis to see what the contents of the urine are. Okay, because there are signs we see in the urine that is the beginning of the end. Okay, I say beginning of the end, it's as bad as that. Once you start seeing protein increasing in sickle cell patient's urine, and you're seeing red cell in the urine, if it's not an acute injury, that's the beginning of the end. Patient is anemic because it breaks down blood. How many times faster than a normal? For an average individual, you have 120 days for blood in circulation. For a sickle cell patient, you have 20 to 30 days. So they have to make more blood than you. And to make blood, you need resources. So that where the folic acid and vitamin supplementation comes in. Okay, so if someone is breaking blood down that fast and again is peeing blood in urine, and there's nothing you can do at that point except you're thinking of a renal transplant. And the kidney you're going to transplant to a sickle cell patient cannot handle that hypoxic state like the original one that had adapted to the situation. You're taking from a normal individual that is ajebo in true terms of it to put in a backhoe, that kidney won't survive. Okay, it's going to be hit, except you do what's it called, bone marrow transplant, and then you convert to HPA before you can think about that. So we talk of oxygen therapy. I still make reference to my colleague who presented earlier. I'm talking about saturation. You're panicking at saturation of 85. A sickle cell patient, that's about his normal. Okay? So if you need to know, one of the things I forgot to say is, once you receive a sickle cell patient, one of the first things you need to do is establish contact with the doctor that is used to managing that patient. You would gain a lot from talking to that person. Even if you're a hematologist, try and find out who's the hematologist that has been managing this patient, because he knows the anti-painkillers that work for that patient. So instead of you trying and failing, you already know what works for this patient and you go ahead. Okay? You know the patient's steady state, you know what saturation the patient sits on. Okay? So oxygen saturation in sickle cell patient might not help much, it just guides us. Once it's dropping, okay, or if it gets below 80 or 75, then you might need to, but at that point, the patient will already be hyperventilating. Okay, so it's key at this point to find out if the patient is actually going into an acute chest syndrome, which is a combination of sequestration and a VOC. That's the care is different. There's VOC going on, but the care is different. It's strictly an ICU affair because the patient can just die, like the nurse say. Okay? So if you don't observe or monitor these patients, most of your patients will just die. Okay, without you having a concrete explanation. The temperature regulation, for this is not a luxury we enjoy here that much. So what was left with is blankets and warm clothing. But where they're available, you use room heaters and then air conditioners. If it's too hot, like in Macaulay, you cool down. If it's too cold, like here, you warm up. Okay? So chronic management. We still talk about pain here. Mostly the pain you're dealing with here is like, okay, it's like pain from avian. That pain doesn't go. You just have to manage the pain. And you trying to be overzealous with NSAID, which improves the pain, might kill the patient from the painkillers than the condition. So you advise for the hip replacement surgery. Okay, so you have hydroxyurea therapy. Now this is a very important part. Most doctors are beginning to learn of hydroxyurea for sickle cell, and everybody wants to throw hydroxyurea at a sickle cell patient. Hydroxyurea is a wonder drug for sickle cell, accepted, but it doesn't work for everybody. It might worsens the condition of some and then improves the condition of others. Okay, and then if you're giving hydroxyurea, you need to know what hydroxyurea does and then how to monitor it, because you can get told. We use hydroxyurea for cancers too, okay, because they are lympholytic. They also affect platelet count. In sickle cell, we use it mostly to even reduce their platelet count because they have very high platelet count, and we know it's a thrombogenic condition. Okay, so you don't just throw hydroxyurea at sickle cell patients. We know it improves hemoglobin F. It helps reduce expression of markers, and then it also reduces the frequencies of crisis. But it doesn't work for everybody, so you choose your patient wisely, and then once you start, you monitor. Okay, because the white cell count will keep dropping. Platelet count will keep dropping. You need to know when to pull out. Okay? Now, blood transfusion, we'll talk about in transfusion. I keep that. We have top up, which is what we do to improve hemoglobin. We have chronic exchange programs like that. Like I said earlier, you don't want them to make their own red cell, which is deficient. So you use transfusion. You schedule transfusion maybe like 2-3 monthly. Okay, they don't need to be anemic, and you just go in, take out blood, and introduce HbAA type blood in them. That will reduce their production of HbS, and that will improve their well-being. Antibiotic prophylaxis, we know most of them have functional asplenia, so you need to give prophylaxis and penicillins in particular. Then vitamin and mineral supplementation, regular follow-up clinic visits, so you get their counts and all. So we have additional therapy, physiotherapy to reduce pain from the joint issues they suffer. You have occupational therapy as it relates to their job. If it's so stressful, you have to cancel them on alternative job, or probably talk with their employer to give them waivers on activity. Then mental health is one of the most difficult parts. Most sickle cell patients are angry with their parents. Okay, most of them never forgive their parents. They feel it's their parents' fault. Okay, so you really need to, because they don't listen to their parents anyway, so you need to step in and bridge the gap. Okay, and most of them are depressed. They might show you that they are up and strong, but inward they need help. Okay, because even if you manage sickle cell patients and you get attached to the patient, you yourself will get depressed. Okay. Now, acupuncture and meditation have been proven to help in some people. So we'll talk about lifestyle modification. Stay hydrated, avoid triggers, regular exercise. When I mean exercise, it's not football. Okay? Healthy diet, avoid smoking and alcohol. So, questions before we conclude.
So thank you once again for taking our time to share with us. So we're going to take questions, just like we did in the other presentation. We'll take the questions at the same time, Please, those of us that are online, if you have any question, you can put it on the chat box. So, if you have questions, let me see your hand now. Okay, 1, 2, 3, 4. Any other one? 4. So help us check the ones online, okay? So let's start answering. 1.
Thank you very much, sir, for the lecture. So my question is, you mentioned stress being a trigger in the disease. So for a pregnant woman who has a sickle cell disease, would you encourage her to go through the stress of labor? Thank you.
Thank you very much, sir. Now is just clarity. Where you're talking about anemia, you're making reference example with parasite 12-fold. Now you did mention about example, PCV less than 29, and then you said the permission will be given in maternity. I would need to clear about what you're trying to say there. Thank you.
Thank you very much, sir, for the presentation.
Mine is just clarification I want regarding hydroxyurea, because I know for a pediatrician, there are patients that have sickle cell disease, like they are on a monthly therapy. So, and you mentioned some of the issues of like on individual basis and the issues of hydroxyurea. So, how do we go about that? Will you encourage the normal monthly kind of therapy hydroxyurea, or it should be individualized?
Thank you for the presentation. My first comment is on the issue of pentazocine because of addiction. One of the conference we had, one of the recommendations is that even pentazocine can be withdrawn because we have to. The very bad dog when it comes to tissues, it's actually destroy tissue and become fibrosis. And for them, they will have exposed bone. You raise a flap, you will fail. It's actually a problem in managing them. And having talked with anesthetists, say that after a few hours or 24 hours, what people get from pentazocine is euphoria, not being relieved again. So that's just the other one is about sickle cell and the leg ulcer. It's one of the chronic presentations we had, and many of them usually, if they present early, we just manage them like a venous ulcer and they do well. Their problem is that they present late. And if you do skin grafting, then they will fail. So these are some of the challenge I have with them. But if they could present early, it's going to actually be good for them.
Thank you, Akor, for the presentation. I have a friend last 2 weeks who sent me a PCV she did in Kano, and the PCV was 10%. I told her it's not true. When you said they can come with 9, I now say, well, I have to call her back. Because I told her, I said, she's been a friend, she's in her 40s, she's a sickle cell disease patient, and she told me that she went to Aminocan AKTH. They told her PCV, and she was having palpitation, easy fatigability. So I said, PCV of human being can be 10. That's 3 grams. So I told her she should go and recheck. She said, no, it's AKTH. I said, no. So she sent me a copy. I said, no. So maybe yesterday she called me, I refused to pick because I just told her that it can't be possible. But with what you said that they can have PCV of 9, I think I will answer her call. With better knowledge, I will explain to her why it can be 9 and things she needs to do. So thank you for that education. I don't know. I don't know about the concept of for the chronic management of bone marrow transplant. You didn't say anything about it. Is They are not sure like that.
It was deliberately avoided, but since you brought it up, we'll talk about it. So I hope the timekeeper will not show me another time.
Okay, no, we will not give anybody. What's okay, the one online?
No.
Okay.
Okay, my question is, what's the experience in attempting to quantify this percentage sickle hemoglobin versus frequency of VOC?
Please, that first question they asked is an obstetric question. I would like to answer it if you don't mind.
Okay.
Yes, because she asked, what do you allow them go to the
Yeah,
okay.
That's not for hematologists.
Okay, no problem.
Yes.
Okay, so the question online is, how do you get around older children, adults who get addicted to pentazocine and present with bone pain that doesn't seem to resolve with other analgesic apart from pentazocine?
What?
Did you get the question?
I didn't get it.
So how do you get around older children, stroke adults, who get addicted to pentazocine and present with bone pain that doesn't seem to resolve with other analgesic apart from pentazocine?
I think the answer for that was in the presentation.
So that's what's up.
Okay. So I have a rescue for the ONG question. So would have him answer that, and then maybe you get my own opinion on it.
Okay, thank you. My name is Shambi, obstetrician and gynecologist. The question you asked, why I said I would speak, because strictly the decision to deliver will not be strictly hematological decision, but it's joint management. We manage the patients together. In of itself, having sickle cell anemia is not a contraindication to vaginal delivery. What you do is you optimize the patient, working together with the hematologist. And the stressors that you are afraid of that may trigger all the crises he spoke about, including the vaso-occlusive crisis, you do all that is needed to prevent that in labor. You rehydrate as appropriate. Yes? Then pain management must be with epidural analgesia. Before then, of course, you would have gotten corrected anemia. Again, working together with them, because like he said, we usually want a higher part self-holding for them, because we know that once they deliver, that blood loss that we have, they do not tolerate much blood loss. In fact, the standard definition that you see postpartum hemorrhage for vaginal delivery, 500 mils, for them, even less than that can tip them into heart failure. So, in fact, what we used to say is that we replace any blood loss mil for mil. Yes? And there are also other risks they have postpartum. There's a rule of 4. 4 hours, 4 days. Yeah, they have risk of all those crises. And those are the times you really monitor them. And we usually heparinize them. So the long and short of it is that if they are you can allow them go into labor. Any decision to have an abdominal delivery will be purely for obstetric reasons. Maybe the baby has a malpresentation or other issues. But it's not an indication to say you're going to do a cesarean section simply because they have sickle cell anemia. I hope I've answered your question.
Okay, thank God we're on the same page. So, like I say, just remove all the compounding factors that can worsen the process of labor and you'll be fine. Okay, if there's no indication we'll try to handle the sickle cell patient as every other patient when possible until there's a specific need to change that. Okay, so the question on hematinics, you needed clarification on that. Okay, so let me rephrase. No anemia is just anemia. If you see an anemia and you don't know the cause, don't treat. Call the expert. That's what I tried to say there. So the mistake, especially with proliferations of private practice, we want to attempt everything. If you have a patient with anemia, you transfuse. or you give hematinics, you calling in the hematologist, he will still come and wait for what you transfuse to be out. Now, let's assume you have folate deficiency or B12 deficiency. That again can be secondary to something. Let's say Crohn's disease or gastritis. What you saw was full blood count. PCV is 24, and then you decide to give multivite. As the name suggests, everything is inside, but not in therapeutic doses. That's not meant for treatment. It's a supplement. Now, the hematologist will come in. He wants to know what the picture looks like. We use morphological assessments to see if in folate and B12 deficiency you have macrocytes. Mean corpuscular volume will be high. But you've transfused. The person's blood you transfused is normal. So a full blood count done after that transfusion will not help. You will just know that this person has been transfused because you'll be seeing two different types of red cell. Okay? Most people don't even request for hematologist review of their slides. You just do a full blood count with a machine. Once the machine sees two sets of red blood cells, it will take the average of the two of them and give you the result, which will fall in normal range. So the only flag in that situation is that you see red cell distribution width, which is a part of full blood counts that most doctors don't even look at. We just do PCV, we'll see white cell count is not high, platelet, then you just dump the results. Those red cell indices will give you an idea what the type of anemia, possibly intervention that have been done, or what you need to do. Okay, in case of iron deficiency, when you have like parasitemia, you'll see microcytes. Okay, if the bone marrow is not doing well, reticulocyte will be low. But if you attempt treatment, we can't even do those investigations. I answered that. So now, for a hematologist like General said, you might have to call that your friend. We are not alarmed by the values. I've seen PCV of 5, and the patient walked to me. Even though we didn't let him walk back. Okay? So the values don't scare us. We see these things. What is the problem is what we want to handle. Okay? All right. So, hydroxyurea in pediatricians. Hematologists, we have a lot of fight. Most colleagues look at us as being laid back. Our ways look that way, but there's a reason. We discussed with the pediatricians on the use of HU. They advocate you give everybody HU. Okay? Because research has shown. Alright? Now, we can't tell them what to do. The same research and practical experience has shown not everybody benefits from hydroxyurea. In some individuals, we usually count the number of crises per year to talk about. There are a lot of things we didn't talk about. That's why I warned at the beginning we are not discussing sickle cell, because we can't finish sickle cell in one session. Okay, there are sickle cell haplotypes. There are sickle cell patients that don't know. In fact, I was rebuked by a woman because I told her she had sickle cell. I'm sure if she had anointing oil, she would have poured me that day, because she was 62, and the only time she needed any intervention is when she's pregnant. Okay, a very senior colleague in ONG invited me to unravel why this woman needed transfusion for every time she delivered. And as a matter of fact, 62, she has stopped delivering, but they wanted to find out why that was. Hemoglobin electrophoresis showed the S band, no other band. So how do you explain that? Okay, now, that's a sickle cell anemia patient with a different haplotype. There are haplotypes that don't have crisis. But what you don't want the day they have theirs, you don't want to be there. Okay? That's the same reason why AS are not allowed to fly the jets. Because you too can have crisis under extreme condition. And when you do, you are not an experienced crisis holder. You will crash that jet and it's not cheap. Okay? Now that's what happens. So we prioritize. I've placed patients on hydroxyurea that I felt very well that these patients are doing very well on hydroxyurea. But all of them kept complaining. Okay, GI symptoms, some will have abnormal metabolism and all. The indications, you take it off. If your drug is doing more harm than good, it's of no use. Okay, hydroxyurea has multiple mechanisms, about 7, by which it works. So, if you, let's say you're giving it just to boost hemoglobin F, if a patient is not having more than 2 crises in a year, why do you want hemoglobin F? Now, how does hydroxyurea trigger hemoglobin F production? It switches off a gene, and that's the fear. Okay, the gene that helps to switch from F to A, it switches off that gene and goes back to F. So if it goes and switches off a tumor suppressor gene, we all know the result. Okay, we use hydroxyurea for cancer care, we use it for CML, we use it for AML. So I don't think the pediatrician should lecture a hematologist on use of hydroxyurea. The research is true, okay, but there's a reason why we hold back a bit. And there might be peculiarity in the younger age than in the older age. If your research or clinical features shows that your children are benefiting from it, by all means, go ahead. But for adults, we know that some patients, you start hydroxyurea and the PCB crashes. You start hydroxyurea, their crisis move from 2 in a year to 6 in a year. Okay, so that's, we usually do our checks before we place on hydroxyurea. Most times we start hydroxyurea because of platelet count. And then once you exceed 5 crises in a year, we want to place you on hydroxyurea and see if it helps. All right. So, pentazocine addiction and leg ulcer. I'm suspecting the person that asked that question is one of them. I mentioned the S in sickle cell, equated it to stubbornness. Now, a patient walks up to me, I'm seeing for the first time, and you're lecturing me on the painkillers that doesn't work for you. You've listed like 7. I say, Auntie, calm down. So which one works for you? He said, no, this one too doesn't. I said, which one works for you? And she kept quiet. Because I knew what she was going to say, penta. She didn't want to mention it, so she went around by telling me, this doesn't work for me, this doesn't work for me, this doesn't work for me. Earlier I mentioned we combine therapy. Penta is an opiate. Morphine doesn't work for you, but penta works for you. You must be very unique. Okay? Fentanyl doesn't work on you, but penta works for you. As far as I'm concerned, penta is not even a painkiller. It's like what they use analgin in those days to do. You think you have fever, if they hit you that analgin, you forget the fever and think of the pain. Okay? So that euphoria you get, the high, like the plastikinos with I'm his very good friend. Penta damages the skin and subcutaneous tissue badly. The scarring is irreparable. The last 2 patients I brought for him, both of them are dead as we speak. The addiction management is something else. Once you're locked to that high, you need grace of God to be delivered from it. Okay, even colleagues are the biggest victim because they have access to this drug. Okay? So if a patient is telling you this doesn't work for me, this look well. VOC, the painkiller that works the most in VOC is diclofenac. We just don't like to use it because of the effects on GI and the renal. And most patients already abuse it and already have GI symptoms. One of the first tests we do in sickle cell is urinalysis, because it tells you the state the kidney is, proteinuria and all that. Okay? So in addressing that question, the question is biased. It's biased towards the love for Penta. Penta can't be the only drug that works for you. And most of the problem is in private practice that put us in this challenge. Most private practice, the doctor is not the first on call. It's our nursing colleagues, and it's regimented. Sickle cell, Penta, normal cell line. I've been called to see one. This patient was bloated like a toad, because they kept dosing with normal cell. I had to call in the cardiologist to remove fluid. So in that patient, fluid management was zero, because they had fluid overload. It was swollen from head to toe, because they kept giving normal saline and Penta. Okay, so let's try and avoid that. Once there's no pride in calling for help. Okay, as a matter of fact, I think specialization has made us all a little bit soft. I always shout for help once it gets outside my field. Okay, now the pentazocine addiction and leg ulcer, I think we've already talked about it. Okay, it's very common. Eliminating it for us is not, it can be done, but we need to grow a little bit before we talk about eliminating penta. It's the opiate that is readily available everywhere, and I talked about the speed at which we need to take care of pain and effectively. So if the patient is agitated, O2 saturation will be affected and all. So we want to calm them first before we move. Well, I don't use Penta beyond 24 hours, at most 48 hours. I switch something else. Okay? So, but as we grow, there are places where they have all the fentanyl patches and all that. We can use that. So bone marrow transplant, I actually avoided that topic because it's a topic on its own. Now, bone marrow transplant it's not a cure, but it turns HBSS to HBAA. When I mean it's not a cure, you're no longer producing hemoglobin S, but you can still have offsprings because your genotype doesn't change. The gametes still carry the gene. Okay, it's doable. It's even done in Nigeria, in Benin. Okay, but you assess the risk. Most times, people just have the funds and want to have bone marrow transplant. As we speak, the success rate is just beginning to approach 60-40. 60 successful, 40 dead. Okay, so in Nigeria, we are not even there yet. So if your patient is not someone that has been debilitated by the condition, you need to choose which patient you recommend that therapy to. And with advancement right now, bone marrow transplant is not even the first. There are genetic therapy with CRISPR. Okay, you re-engineer the virus you introduce into the body, and it goes there to do the gene edition. Edits the gene, remove the abnormal gene, and puts the normal one there. Okay, 2 patients had that CRISPR therapy because it's approved now by the FDA in the US. They had it, I think, last month, and 2 of them were successful. Okay, so it has less risk than the bone marrow transplant, and it's been developed because that's the current treatment for cancers too. They call it the CAR T cell. You re-engineer you take out the present cell, re-engineer the cell, and reintroduce it. So there's nothing like rejection and it's the present cell, or you alter some gene. So that particular T cell, the normal T cell you took out, now goes in search of the tumor cell. So that you're not even talking of minimal residual disease. Anyway, that residual cell is the T cell is going to take it out. So that's what we use for multiple myeloma currently. That's what we use for most lymphomas also. Okay. So bone marrow transplant is still an option, but the gene editing is simpler, well, more expensive, but it's simpler with less risk. Okay. So free hemoglobin and crisis. Yes, it's something, they are linked. Okay, I think it's a research topic you're considering. Free hemoglobin, like we said, we talked about the pathophysiology, is linked to vascular tone, is linked to renal health. Okay, free hemoglobin, like myoglobin, can destroy the renal tubules. Okay, so for patients with free hemoglobin, you know, in sickle cell, we go ahead to classify them into hemolyzers and then what's the sicklers. Okay, that's for we the manage. There are sickle cell patients that hemolyze the most. Those ones you always see their eyes are yellow. Okay, those are the ones that have most of the breakdown thing, and they are the same people that have more priapism. The ones that don't hemolyze that much, their PCVs are always above 30. Okay, D are the ones that have crisis the most. Okay, because they can hit the critical mass of hemoglobin S that triggers sickling. Okay, the management of both of them are different. Okay, so I know Dr. Onuminja must have seen plenty of our turgid cases that we need to deflate. Okay, older children to an addiction, it's the same thing. I think addiction needs to be managed by the psychiatrist. Yeah, so once the addiction is in, there's a big problem. I give you a scenario. Two of our patients, I think, siblings, they died the same year. Okay, the parents are wealthy. Both of them were addicted to pentazocine. They started injecting themselves. Okay, the sister injects the brother injects the sister, and the sister had the plug that supplies the penta. So they had to do a skin graft in India, the whole arm. So there was a day they came in emergency, there was no vessel because the skin graft did not leave any vein for you to even set line. That was my first attempt at a neckline. I'd never set a neckline, but I was confronted with that situation. If I get it wrong, the patient dies. If I don't get it, the patient dies. So I attempted. Luckily, I was successful. Only for me to hear 2 days later, she OD'd on another drug and died before they made it to the hospital. A month later, brother too OD'd on another drug. So there's the point where you go on that pentazocine, it's not even sufficient. You start looking for another drug that gives you a better high. Okay? So I think, okay, the slide has been changed. My conclusion basically is VOCs, the management is multidisciplinary, as we've seen, and then your high index of suspicion and knowledge of his pathophysiology is key in making the right diagnosis and management. Thank you.
Thank you very much, sir. Again, we are sorry for short time.